Hello, everyone. My name is Dee Williams, and I am a doctoral student at Maryville University. And this is my DNP project on improving hypertension follow up in primary care. First, I would like to thank my chair, Dr. Teresa Gallicados, who was instrumental in guiding me through this process and giving me the support I need to be successful. I would also like to thank Dr. McFadden for her support and Dr. Snell for her commitment to this program and her leadership. First, I want to tell you a little bit about myself. I obtained my BSN at Central Methodist University, St. Louis, and then later on went to Maryville University of St. Louis to obtain my master's in nursing. Maryville's curriculum and their instructors are so exceptional that I decided to return to Maryville for my DNP. I am currently a family nurse practitioner practicing at a community health clinic. So let's talk about hypertension. Hypertension in primary care is a problem. Patients consistently come into the clinic in either hypertensive crisis, where they would need to be taken to called an ambulance called and taken to the emergency room, or their blood pressures are significantly high and they have to be medicated and stay in the clinic until blood pressures are acceptable enough for them to leave the facility. According to the American Heart Association, a normal blood pressure should be 120 systolically over 80 diastolically. This quality improvement project aimed to improve follow-up care in the primary setting due to these issues that we were facing on a daily basis. Coping strategies were created to focus on promoting lifestyle changes. So those type of lifestyle changes the coping strategies addressed were low sodium diets, regular physical activity, stress reduction, medication adherence, self-monitoring, and timely follow-up care. The significance of this project was to reduce the number of patients in hypertensive crisis or urgency, improve their self-management, and improve the overall outcome associated with hypertension. So let's take a look at the literature. There were themes associated with this project. Risk factors that were associated were modifiable risk factors, and then there were non-modifiable risk factors. Management was talked about in the literature about how patients could manage their blood pressure and the things they could do. With the modifiable risk, those were the ones that we worked on with patients the most with this project. Obesity, poor diet, smoking, sedentary lifestyles. Those things were the main reasons for the elevated blood pressures in certain patients. The non-modifiable risk were those things we couldn't change, which was age, race, family history. Those things could not be managed with these coping mechanisms, coping strategies. Those things couldn't be managed. But those things that could, the literature states that blood pressure management must be tailored to the individual to obtain targeted blood pressures. One of the aims of the project was to mitigate the barriers to hypertension control. So, transportation issues were the problem for some people. Limitations with food insecurities was a problem for some people. They ate the food that they could afford. Fresh greens and vegetables They couldn't afford those things because they tend to be more expensive. So even low health literacy was one of the things we wanted to work on with this project. So by addressing these social determinants of health, we can reduce disparities of hypertension. So some of the strengths in the literature were lifestyle changes, self-monitoring access, education to patients, 90-day prescriptions instead of 30-day prescriptions, coping strategies. These were some of the strengths that found in the literature. Some of the weakness were, of course, those barriers, those things that prevented patients from being compliant, the non ability of them to monitor blood pressures at home, no consistent follow-up care. Patients were returning back to the clinic only in urgency once a year or every 6 months, but not on a maybe every quarterly basis. So variability in the implementation was another weakness. Worldwide, hypertension is the primary modifiable risk for cardiovascular disease, contributing to almost 10 million deaths annually. So, the theoretical framework that I used for this project was Dr. Irving Page's mosaic theory. For this project, it conceptualizes high blood pressure as the result of a multi interrelational, physiological, behavioral, and environmental factor. The theory states that hypertension is not just caused by one single factor, but by a mosaic of contributors. The mosaic theory justifies the uses of multifaceted clinical strategies. So these coping strategies that we were using for patients needed to be the multifaceted clinical strategy that's implemented in this mosaic theory. Thus, theoretically, the framework gives rationale that comprehensive person-centered, system-aware interventions is needed to achieve sustainable blood pressure control in a diverse community. These populations, there are certain combinations of medications, there are certain things that has to be done in order for blood pressure to be controlled in this population. So Dr. Page theory originated in about the mid 20th century, before the full extent of inflammation, the inflammation role on cardiovascular disease was really understood. So inflammation contributes to endothelial dysfunction, which also contributes to hypertension. So inflammation does not act alone. It combined with stress, it combined with diet, it combined with some genetic factors can amplify blood pressures and cause dysregulation. So sodium is in everything. We teach patients about sodium when dealing with hypertension. We tell patients your sodium should be less than 1,500 milligrams per day as a hypertensive patient. Dr. Irving Page proposed that when the kidneys can't excrete the sodium, this leads to an expansion in the cellular fluid, which leads to higher cardiac output, which leads to elevated blood pressures. So getting patients to realize that their sodium intake can cause an issue with blood pressure It's a part of the educational process that was used with these coping strategies. So let's talk about how much sodium is in certain foods that we encounter every day. Coffee. A lot of people wake up with a cup of coffee every day. 11 milligrams, not too bad. But let's say you want a slice of bacon. One slice of bacon holds 180 milligrams of sodium. Let's say you want to make that bacon a sandwich. 2 slices of whole wheat bread is 280 milligrams of sodium. So let's put that into perspective. So for breakfast, you've had 1 cup of coffee, a slice of bacon, and 2 slices of bread, and you're almost halfway to the allotted amount of sodium per day. We teach patients that 1 teaspoon of salt equals 2,300 milligrams of sodium. These things are important when addressing hypertensive patients. So let's talk about the methods and the design of this project. A retrospective review, pre and post design, was done in an outpatient clinic, September through December of 2024. This quality improvement project was conducted at a community-based clinic. The pre and post intervention design was used to evaluate the impact of implementing the coping strategies. So data was collected by retrospective chart review. Medication refills were checked. Hospital follow-up lists were also checked. The IRB approved this project. Let's take a look at the sample size. Sample size was 32 electronic medical records that were reviewed. It was only associated with patients who had a diagnosis of hypertension. Patients' ages range 18 through 99. African American patients were the only patients in the sample. Data collection. Blood pressures were monitored before the intervention and also post-intervention. Patients were checked according to the blood pressure readings that they came into the clinic with. None of that was modified. Patients were asked questions about transportation needs, medication needs, and reasonings for not being able to sustain a normal blood pressure or adhere to medications. And those things were discussed during the data collection before the intervention. The data analysis. There was a lower Z tail Z test done with the difference of 2 proportions. When looking at statistical data, a Z test is used for known populations. So we knew the population that we were studying, and those samples should exceed at least 30. And so our sample started off with 32 patients. 2 dropped out, so it left us with 30 patients. The Z test yielded us a negative 2.5820 with a p-value of 0.0049. The pre and post outcomes were different because the significance level was a negative 0.05. This was strong evidence showing the significant reduction in hypertension using this new protocol. Let's look at the chart. So this chart is about the readmission rates. In the red, you would see that at, at the beginning of this study, patients were consistently going into the hospital, and those rates kept elevating, elevating, elevating. But once the intervention was introduced to patients and they were taught coping strategies, they were taught how to use medications, they were taught what things they should eat, exercises they can do, breathing exercises, all of these different coping mechanisms taught to patients. You can see that the blue line represents that no patients entered into the hospital after the intervention. So this proved positive for these results. 20% of the patients were admitted to the hospital before the coping strategies. After the coping strategies were implemented, none of the patients were admitted. So let's talk about the limitations with this project. So some of the limitations were the no-show rates. A lot of patients were no-showing and not coming to the clinic appointments. It was a smaller sample size than we actually anticipated because so many patients come into the clinic in hypertensive crisis or urgency, we expected the sample to be a little higher. Um, there are no home monitors used with this project. Um, People did not have home blood pressure monitoring systems. We had that program at our clinic for a while, but when funds ran out, we were not able to supply those home monitors for patients. Um, the short duration of the project. After 3 months, the project was over. So I felt that was one of the limitations with the project. And also, there was no diversity. This project was done at the same clinic with all African American patients. I would have liked to see it done with a more diverse group of people. So, the discussions with this project um, that were talked about were provider patient education. We discussed diet. We discussed exercise. We discussed medication adherence. We discussed stress relieving, like meditation, breathing exercises. Some of the findings were discussed with the coping strategies because these findings improved outcomes. Patients' blood pressures improved at their follow-up visit. So in primary care, when patients returned to the setting, they were not in hypertensive crisis. So the coping strategies were associated with the lower blood pressures. Let's talk about some implications for practice. This project is sustainable because it encompasses a holistic approach that integrates environmental protection, social equity, and economical viability. Coping strategies are easily taught and they are able to treat hypertension to help patients be more effective. Nurse-led modifications during the office visit really helped patients also to understand arm cuff position, teaching patients to uncross their legs when taking their blood pressures, to have their arm at heart length. A lot of these different strategies helped patients and helped everyone apply these things to help blood pressure to be treatable, sustainable, and effective in the clinical setting. Now, I would like to talk a little bit about some of the DNP essentials that I feel um, added some depth to this project. So, domain one, the knowledge for nursing practice. The design and implementation of coping strategies demonstrated the advanced application of interdisciplinary knowledge to guide innovation and clinical judgment in patient care. Essential number 5 was another one, quality and safety, that stood out for me because coping strategies reduce complications. So the project fostered a culture of continuous improvement by using data to monitor outcomes to reduce those things like missed appointments, and it helped reinforce high quality care in patients. I want to also talk about domain 6, interprofessional partnerships. This was kind of big for me because collaboration improves health outcomes in patients. When you collaborate with the social worker, and when the social worker collaborates with the practitioner, and when the practitioner collaborates with pharmacy, and all of these things, the interworking of this project, it demonstrates intentional interprofessional cooperation to enhance care delivery and patient outcomes. Patient improves so much better when the professionals collaborate to make uh, hypertension uh, sustainable. It helped me continue teaching my patients and giving them the information that they needed by collaborating with other uh, people to get them to a standard of good health. Domain 7 is system-based practice. Refills. Refills for 90 days, not 30 days. Allows the patient to have some consistency with medication adherence. Patients will constantly take that blood pressure medicine, but once they run out, that was an issue. So 90-day refills for medications helped patients stay on track with the medication. Home monitoring systems that are linked to the EMR. When patients take their blood pressures at home, that system linked to the EMR alerts the physicians or the practitioners that that patient either had too many high blood pressures that day or too many low blood pressures that day. And it gives you a connection so that those patients who come into the facility that have white coat syndrome or things like that, who are elevated because of the visit, we would see what those blood pressures were at home and they're relaxed in their own comfort, and see if that blood pressure is still elevated. And it'll give us a way to align the healthcare system based on that system, that monitoring system. Let's talk about domain 9, professionalism, accountability, advocacy, compassion. These are all the things that I try to hone in my practice. So this essential was important to me to talk about because it reinforces the nurse leader role in promoting equity, evidence-based care, ethical practice, especially in underserved communities. These communities want the same treatment. They want the same uh, amount of care and time that other people have. So this domain meant a lot to me because it holds me accountable to be an advocate for my patients, to have compassion for them, and to be professional when I am dealing with their health care because they deserve the same treatment as those who are in a better position in life. Domain 10, personal professional leadership development. Leading this QI project offered so much resilience, and it's lifelong learning, committing to an ongoing profession. This profession is constantly growing, it's constantly learning and teaching and training. So your leadership abilities have to be strong. And professionally, you want to continue to develop in this capacity because you want to know the new medications, you want to know the new treatments, you want to know what works and what does not work to continue to give good professional and continual care to your patients. In conclusion, coping strategies were effective to reduce and improve hypertension in follow-up care. Medication vouchers were given to patients who did not have money to buy medication. Transportation vouchers were given to patients. They were able to get back and forth to visits and be get back and forth to the pharmacy. Pharmacies who deliver were given to the patients who were not able to, who didn't drive. Uh, those things all were a part of this project. Cost saving from avoidability from hospital admissions. This project is sustainable by integrating into existing workflow, by using evidence-based interventions that can be replicated and give patients empowerment through self-management. So stakeholders can even buy in by sharing outcomes with measurable improvements. I could not be more proud of this DNP project. I am not only making a difference in my community, but I am also saving healthcare costs by keeping patients out of the hospital and teaching them how to manage their blood pressures. I would like to thank you for your attention and your time. If you have any questions, I may be reached at Dee Williams 18 at live.maryville.edu. Thank you, and here are my references.